All right. Well, I think we'll kick it off. Welcome, everyone, to our first session of the National Board of Physicians and Surgeons Brand New Leadership Academy. Quick background, we decided to give this a try and start these series of seminars because we know that there are a lot of common questions out there, specifically about the national healthcare landscape and how the National Board of Physicians and Surgeons fits in. And we have a lot of information in our brain, and we wanted to share it out with you to bring everyone up to speed on what we know and what we've learned and how we can help advocate in the landscape. So welcome to our first session, Payors and Accreditation. I can't think of a more dry topic, and we're so thrilled. We have a full house on Zoom today, and we'll try to make it as interesting as possible at the end of your long, busy day. And I'm going to kick it over to my colleague. I should introduce myself. I'm Karen Shatton. I serve as the Associate Director at the National Board of Physicians and Surgeons. I'm going to kick it over to my colleague, Katie Collins.
Hi there. Welcome, everyone. So glad to have you all here tonight. My name is Katie Collins. I'm the Executive Director. I've been with the National Board for almost 10 years now. So I'm going to go over, before Karen presents, I'll just go over some of the housekeeping. Karen, there you go. Perfect. So this is, as you can already tell, this is a one-way webinar. We had over 500 responders and registrations, so it's very, very exciting. And so this will help keep things moving quickly, and as well as keeping distractions to the minimum. So we are recording this, so if you have to take off or you can't stay for the full presentation, we will have that on our website, and we'll be following this presentation with an email with more information and a link to that website so you can find the recording. For questions and answers, we definitely want to get to your questions. This is a hot topic, and it's also obviously a complicated topic. And so you'll see at the bottom of your screen, there's a QA with a question mark in a box. That is where I will be grabbing a few questions, and Karen's going to stop periodically through the presentation to answer questions that we find in the box. And if we do not get to your questions, because there are quite a few of you, we really do want to get to them. So please send us your question to the info@nbpas.org inbox, and we will get back to you and make sure we get your answers to your questions. We are also very excited about this being our first. We have several sessions that we'll be planning, and the next session will be about state licensure and the Interstate Medical Licensure Compact, which we get a lot of questions about, and we'd love to share more about that. And we've planned that for May 20th at 7 p.m. as well. So look forward to seeing you then, and hope you can join us. I'm going to kick it back to Karen, and we'll get started.
Okay, so without no further ado, we are going to talk about payors and accreditation and the landscape in which this all percolates. So an agenda for our talk tonight, we're going to give an overview of the national accreditation requirements for health plans, talk about CMS's role and what their rules are in terms of oversight of that accreditation process. Then we're going to pivot specifically to what we really care about here, which is what is the standards for physician credentialing by payors. And then some really important distinctions that I want to talk about. The first one being board certification versus something called primary source verification. I'm going to talk about what happened when the National Board of Physicians and Surgeons arrived in this very complex web of regulations, and how we navigate common misunderstandings and help you navigate common misunderstandings. Talk about what it's like to credential and enroll with a health plan, whether you're a CMO at a hospital and you are writing a contract, or you're an individual physician in private practice, negotiating your contracts with payors, what that looks like. And as part of that, talk about some really, really important words. Words make a difference. And so we're going to talk about some of those key words to look for, to put on your radar to help you with that process. We're going to look at actual NBPAS friendly policies with some major national payors who have welcomed us in recent months. Talk about a little bit about payer tracking and why it's so tricky, and also who makes the decisions. Where does the power lie in this decision making, and how can we positively influence a change? And finally, to that last point, talk about the overall value of the National Board of Physicians and Surgeons and the value we can bring to the payer landscape, and of course the wider healthcare community. So that is what we'll be covering. As Katie mentioned, I'll have kind of two built-in pauses where she'll try to look for some questions in the chat. If there are none, we'll continue, but it'll give us a couple opportunities to talk about what we just covered. So to start, what's important to know is that CMS does not directly scrutinize health plans. They delegate health plan accreditation to private nonprofit organizations. In this little graph, you can see there are two primary accreditors that are most well known if you deal in the payer landscape. The orange box on top, NCQA, or National Committee on Quality Assurance. The second one is known as URAC, Utilization Resource Accreditation Commission. And then there's a third in the blue box below on the left, the AAAHC, which primarily deals with federal employee and ACA plans. You do not need to memorize these acronyms. There will not be a quiz at the end of this talk. But the key takeaway that I want you to put a pin in, really to understand, is that CMS outsources to accreditation to these organizations. These organizations then step in, work with health plans, review their policies, and they make sure that they are meeting or exceeding CMS standards. So it really begs a question, is health plan accreditation actually required? Sort of, is the answer. Not exactly, but you'll understand why most plans do get accredited. So health plan accreditation is required for, like I said, most plans. So for example, any marketplace plan enrolled through the ACA or Affordable Care Act, Medicare, Medicaid plans, special needs plans. Many states actually require accreditation for commercial and or state employee health plans. And then another very large group of employees, the federal employee health benefits plans. So if you look at the totality of that group, we can effectively say, and here's the key takeaway, nearly all payers are choosing to accredit their programs. One, because there are very few gaps in who is not allowed to be accredited, and they like it. I can't speak as a payer, but I would assume that they like the quality stamp that it provides to their plans. So now we're going to go a little deeper, and the next step is, okay, so we know most plans are accredited. What do they actually require for physicians, which is really what we're concerned about tonight. So this is one of the biggest misunderstandings that we run into all the time. This is my dramatic pause, and I will tell you, ta-da, board certification is not required for health plan accreditation by CMS. There's something else required, though, that's related, and it's called primary source verification. So put a pin in that. We're gonna keep digging deeper, peeling the onion here about what is primary source verification. So it's really not that complicated. Primary source verification means verification of credentials from a primary source, which is the entity with legal responsibility for the originating document. So if you wanted to primary source verify that I actually graduated from college, you would call the college. That would be the originating source of my undergraduate degree. So obviously in the physician world, the primary sources would be medical school or your residency program, and of course, board certification. So what is primary source verification required for? The highest level of credential, not every single one, the highest level. So in the physician world, your world, what does that mean? There are three main elements that require primary source verification as required by CMS, delegated to the accreditors, that now is at your doorstep to be verified. Number one, education, your highest level that you have achieved, which could be medical school, residency, etc., your state licensure, and finally, board certification. So here's where it starts to get interesting, because let's talk about board certification for a moment. There are nearly 500 physicians on this Zoom call tonight, and we know that nearly all physicians in the United States today achieve a board certification. Number two, board certification is the highest level of education and training as a physician, which means if a credentialer verifies your board certification, they're automatically verifying all the educational prerequisites that led up to that credential. So we know you graduated from medical school. We know you finished residency. We know you passed your exam. Hence, the takeaway here is doing or performing primary source verification of board certification is the easiest, fastest, most straightforward way to achieve that primary source verification that CMS requires in one step. Okay, fine. So why is that important? Quick recap before we move on. So we know now CMS does not generally require network physicians to be board certified, but they do require primary source verification if a physician puts forth that they are board certified. So not required, but must be verified. CMS will accept that verification of board certification as proof that we have verified your highest level of education and training. It's the easiest way for anyone credentialing or enrolling a physician to verify all your training in one step. And also, where do we have to go for that verification? The originating board. So you typically go to the originating board to verify that. And who is the originating board? Well, in the United States, the American Board of Medical Specialties aggregates and sells board certification data for all its member boards, AOA for our osteopaths, and about 100% of physicians in this country are board certified. So for many, many years, every entity that needed to credential a physician would go largely to ABMS or AOA to perform primary source verification for board certified physicians to ensure they were meeting that accreditation standard. So that is the background. We're going to do a quick pause. Katie, you can let me know if there are any questions popping up so far.
Not so far. So we are
Okay.
good. You're
Okay.
doing great.
All
Thank
right.
you.
So we'll continue. All right. So next, I want you to now, you're used to thinking like a physician. I want you to, for a few minutes, try to think like a credentialer. So put on a credentialer hat, and we're going to look at what a credentialer typically sees when they look at payer policies. This, I believe, is from Blue Cross Blue Shield, Highmark Blue Cross Blue Shield in Pennsylvania. So it says the credentialing process will include verification of board certification, if applicable, which is kind of an interesting asterisk. And these elements are verified through the primary source. Next, from that credentialing perspective, okay, the policy says it must be verified. Did it say board certification was required? No, but it also had this kind of mushy area where it says if applicable. We're not sure what that means yet. Again, we also know that ABMS and AOA provide nearly 100% of initial board certification in the US. And prior to our existence, credentialers would reflexively go to ABMS and AOA in order to perform primary source verification of these certifications. So what happened in 2015? Enter NBPAS, NBPAS into the mix. So I know that many of you are physicians certified with the National Board of Physicians and Surgeons, and I know that there are a number of people on the call tonight who are new to us. So in case you are unfamiliar, NBPAS requires initial board certification by an ABMS or AOA member board without exception as a prerequisite, as an entry point for our certification. So NBPAS already performs primary source verification of ABMS and AOA board certification data. We do it for our purposes to make sure the physicians who are applying to us are meeting our criteria. And so in actuality, NBPAS meets national accreditation standards for payers even in 2015, but awareness of this lagged far, far behind. So instantly, there was credentialing confusion. We would get calls, hey, I'm not really sure if this works. I'm not sure if this is allowed. Does this count? Can I credential this physician? I don't know how this jives and how this aligns with our policy. So light bulb, we knew that accreditation standards needed an update. You know, Katie and I often say that our experience with the credentialing world is, we call it a see it to believe it environment. And you really do need to have things enunciated clearly in writing because it's so complicated. And ultimately, everyone's trying to do a good job. No one wants to make a mistake. And we want to make it as easy and as straightforward as possible for someone who's trying to work through all these requirements. So we engaged with all the major accreditors on health plan and the hospital side. And so I'm going to show you what happened with the NCQA's language regarding board certification, verification of board certification. So ignore the box for a moment. That box is what was added after we engaged with NCQA. But prior to that little addition, you can see what it says. Board certification for MDs or DOs can be completed, or verification, I should say, of board certification can be accomplished through ABMS or its display agents. There are other sources, AMA master file, AOA, and then this was the addition. So if you are a board in the United States that is not a member of ABMS or AOA, and they named us, and then they have the criteria. They have to basically ensure that we attest that we perform primary source verification, and then we were good to go. So, you know, we were hopeful that at this point it would be smooth sailing, but as it is, healthcare is a complicated beast. And so what we found, we still had some flat tires and we ran into some common misunderstandings. And so we're going to talk a little bit about what those are and how we navigate past them. The point, I want to step back for a minute and talk about one of the main points of friction here in credentialing physicians in the payer world. So any physician who has practiced medicine for more than 20 years, going back to the early 2000s, knows that when maintenance of certification, or MOC, was introduced, there was a big change in how physician certification status was reported. And ABMS now removes certification status for physicians unless they participate in MOC or if they have grandfathered status. So again, pre-MOC board certification was defined and understood as meaning initial board certification. In the post-MOC world, ABMS has married the definitions of initial and continuing to mean one thing. So if you think about it from the credentialing standpoint, they're used to seeing one word, which is board certification. It used to mean one thing, and suddenly it means something a little bit different. So what happens when you actually go? So I'm going to show you a page from a publicly facing ABMS database, which is called Certification Matters. And I'm going to show you what a credentialer, you're not allowed to share the private database. Those are all paid for private proprietary contracts, contractual relationships with ABMS, but this is publicly available on their website. So this is an example of a physician currently certified or listed as currently certified, but they have grandfathered status. This physician is very special to us because it's Dr. Paul Tierstein, who's our founder and president. And it's really interesting when you look at this because it says that this doctor is currently certified, but is he actively maintaining certification, which means MOC? He is not. So he is currently certified by virtue of being grandfathered. His status is certified in internal medicine. His status is certified in cardiovascular medicine. He is not certified in interventional cardiology because he missed the cutoff for the grandfathering by, I guess, about a year. So that's what it looks like to a credentialer when a physician holds a grandfathered status. But what happens when a physician is younger and does not hold that grandfathered exemption? Well, you're going to see it's going to say no longer certified. So here is another physician. Your doctor is no longer certified. I de-identify the information. And this is a family medicine physician, no longer certified. Hospice and palliative medicine, no longer certified. And again, this is a physician who is currently certified with the National Board of Physicians and Surgeons, But if you're a credentialer with that credentialing lens, looking at this, their job is to verify if a physician is board certified. And many times, this is the place they go to, and this is the information they see. So a couple things happen. Oh, quick recap. ABMS and AOA, as I think is well established, are the primary sources for board certification data. They control it, they sell it. Most people go to them to verify it. We know now, and I gave you an example of what it looks like when a physician is listed as not certified without MOC or OCC, and what it looks like if they have the grandfather exemption. So a credentialer logging in there sees not certified when they go to primary source verify a physician's board certification. So two things commonly happen. One, they're either unsure how to proceed, or two, they believe that the physician simply does not meet that criteria and cannot be enrolled in the payer network. So what's our focus? So our focus has been, one, let's just introduce NBPAS because we're newer. So by definition, we need to educate people about our program and our policies. And two, a larger and important goal is to eliminate the impacts of MOC/OCC status reporting on physician credentialing and ultimately on employment. Another quick pause. Katie, do we have any questions popping up, or shall I continue rolling?
We do have one question. We have two questions.
Okay.
One, can you elaborate a little bit more on what does it mean by selling the data?
Sure. Yeah, so it's a great question. So I mentioned that because of CMS rules, everyone must accredit and verify that a physician who says they're board certified is board certified. So ABMS aggregates all the board certification data from its physicians. They have a separate subsidiary called ABMS Solutions that sells essentially data packages. So if I were Karen's insurance company and I employed 200 physicians and I needed to verify it, I could engage in a contract with ABMS to purchase that data. And that would allow me, I'm sure they have different setups and I can't speak to them all certainly, but that would allow me to query their database, either as a pay for pull, pay for verification, or like a contract, an unlimited open-ended contract type of thing. And so that's how they sell their data. They secondarily sell the data by selling it to, I didn't get into this for the purposes of tonight, but there is another group of organizations called credentialing verification organizations. So imagine if you were HCA hospital system and you had, whatever number of hospitals they had in many, many states. Some companies want to outsource their credentialing because it's so much work. So they may outsource to one of these CVO companies who would then buy the data from ABMS to engage in that primary source verification process.
Great. And the next question, how do physicians maintain their certification with the National Board of Physicians and Surgeons?
Great question. So we're not going to really get heavily into the clinical, this is not about the clinical requirements tonight, but I'll rattle through them quickly because I think it's a great question and important to know. And we'll see what it looks like when a physician maintains with us as well. So as I said, the prerequisite for entry is previous certification or an initial board certification through an ABMS or AOA member board. And then we have a 2-year look back period for CME, and you must submit a minimum of 50 hours of PRA Cat 1 CME in your specialty. And we hand verify those credits to make sure one of the questions we get often is, well, how do we know that a dermatologist isn't interested in, studying, I don't know, psychiatry? And, my answer is always the same. They can study anything they want, but if they want to maintain their certification with us, they have to be showing proof, verifiable proof of their specialty specific learning that's relevant to the field they practice in. We also have some surgical privilege requirements for anyone that has an interventional or surgical specialty to ensure clinical skills, and active and unrestricted medical license, of course, as our professional component. And we'll share our website later too, if you want more information about some of those specifics. Anything else?
We have a lot of questions. I'm going to try to answer them within the Q&A box, and maybe for the sake of time, we'll keep going and then we can answer more questions at the end.
Okay, great. I'll keep going and we'll have much more time for Q&A at the end. Sounds great. Okay, so now we're going to I'm going to ask you to put on a different hat, and that's your NBPAS physician hat. So you may be already NBPAS certified, or you may be thinking about it. And so let's talk about what happens, where does the rubber meet the road when you are credentialed, certified with NBPAS, and now you are going to enroll in a payer network. So this is what it looks like. Credentialers can go into our system. Again, we're going to use Paul Tierstein, our founder, as an example. So as of March 26th, he is certified. He is certified in internal medicine, cardiovascular disease, and interventional cardiology. And that information is primary source verified. So I think before we get to the actual payer policies and I show you examples of how we fit in, I think one important question I haven't answered yet is, we've established that CMS does not require board certification in their accreditation rules, but can payers? Can payers go above and beyond the base requirements of CMS and ask for initial or continuing certification? And the answer is yes. Payers can and still do require board certification and or some form of continuous certification. And I think it's important to say, especially if you're new to the National Board of Physicians and Surgeons, we fully support initial board certification because there's really good data and we know that the initial board certification confers lifelong benefits to the excellence, the clinical excellence of that physician in a career-long sense. However, in the continuous certification side, NBPAS is rapidly gaining ground. So I'm going to show you in a moment what that looks like. So what happens, okay, again, when a physician chooses NBPAS over MOC or OCC? So let's take a look at these important words that I mentioned early on, words that matter. So when you look at a credentialing policy and you're looking to see how NBPAS fits in, first two words to be aware of are current or active board certification. So these generally mean that you have to participate in some MOC or OCC requirement or hold a time unlimited exemption through grandfathering. But increasingly, we're seeing this may also include NBPAS if it's specified in the policy. And you'll see an example in a moment. The word maintain is important to look out for. Some form of continuous certification is generally required when you see any word of maintenance or maintain. Again, this could be MOC, it could be OCC or grandfathered status, but now we're seeing increasingly, we're very happy to report it often includes NBPAS. Initial or previous board certification. So these policies are talking about the initial board certification, the final exam you take after residency. In this case, policies may either be silent on continuous or maintenance, or they might provide additional language for color and verification. And then the word recognizes, which actually is probably the best word because it's simpler and it's more straightforward, and a payer may simply state which certification organizations that it accepts. And then exception or equivalency, these are sometimes standards that are essentially carve-outs in credentialing policies that companies give themselves room and leeway. They really do understand. The longer Katie and I have done this, we find that payers really do understand that there are some outstanding physicians out there who may not fit into a neat little box. And so it gives them a carve-out to examine a physician's credentials more holistically. And so let's look at the actual policies now. This one may be our favorite. This is Blue Cross Blue Shield of Massachusetts, and they really were a leader in adding the National Board of Physicians and Surgeons to their policy. I mentioned the word recognize, there it is, and they simply name which organizations they recognize, and alongside the traditional two is the National Board of Physicians and Surgeons. Second policy I'm going to show you is Elevance. So if you're familiar, Elevance Health, you may know it as an Anthem Blue Cross Blue Shield, which was what its former doing business as name or names were. And this Elevance policy change we just announced recently in January. And this one's very, very interesting. So in the opening part of the policy, it says the applicant must have current in-force board certification as defined by ABMS or AOA. So that tells me they're asking for a physician participating in MOC. But interestingly, they have a new section with alternative pathways to be enrolled, and they're asking for previous board certification, which has expired, and a minimum of 10 years of clinical practice. And so we had a physician say, well, that didn't say NBPAS. Well, they didn't have to because it includes NBPAS. And so what they're essentially saying is they're focused on that initial board certification, the initial exam. They want to see proof of practice for 10 years. NBPAS does require all of its physicians to stay current and active in their field of practice. So this is an interesting and different way to do it. And I actually just want to pause for a moment and share a really interesting story. So we became aware of the Elevance change just in January. And right around the time, or right before this came across our desk, we received an email from a critical access rural hospital in Illinois. And every hospital and every surrounding hospital had closed their OBGYN and labor and delivery units. And there was one hospital left serving, hundreds of thousands of patients in a very wide catchment area. And they had a terrific OBGYN willing to come on staff, very experienced. And she certifies with NBPAS. And the chief of staff called and said, I think we have a problem. Elevance said they won't credential your physician. And I said, right as that conversation happened, this new Elevance policy came into view. And I said, give it a try. And I shared the policy and I said, I don't think so. I think this is going to be just fine. And sure enough, it was. And so this maternity desert was immediately alleviated due to the ability to hire a board certified physician. So these policies they're wordy, they're tough, but they're important. And these words really do matter. And it makes a difference. We see every day how it makes a difference in people's lives. So kind of coming up on our final key takeaways, credentialing policies really can be quite confusing. I'd urge you to review and really be familiar with those words that matter. I would also say, kind of like the example I just gave you with Elevance, don't accept a quick no for an answer, because sometimes these companies are quite large and there could be a policy change at a high level and it hasn't filtered out yet to all the subsidiaries. Make sure that verifying board certification and requiring board certification, they're two very different things. Initial, continuing, maintenance, all the individual words are very, very important and impactful on what's actually being asked and required. And our experience is very experienced people can even themselves misunderstand. So it's important to ask. Don't take that initial no as gospel. It's always good to ask for clarification and ask for the policy language in writing. And certainly if you find something that doesn't seem, that seems to be a barrier, we don't want any flat tires on the road. Our job is to fill the tires for a smooth trip. So always reach out to us, forward us that information, and we will immediately, reach out, educate, and continue advocating for a policy update. After all of this, you might just be saying, geez, Louise, I've had a long day. Just give me a list of payers that accept NBPAS, and I don't have to look at these policies and figure anything out. We get this question a lot. Do you have a list on your website? Can you just give us a list? And we don't. And I hope you'll understand why. So the payer world's really complex. There are over 6,000 registered payers in the US, and insurance is regulated at the state level. So you have 50 different states with 50 different sets of rules. Policies can and do vary by state, even sometimes within the same company. And then any particular company can offer many plans under their corporate umbrella. There are Medicare plans, Medicare Advantage plans, private plans, employer-sponsored plans. So there's so much nuance that we never want to say something and inadvertently give you the wrong information. The bottom line is you've got to it's important to do due diligence and check. But here's the good news. So I'll end this slide on really good news. The good news is that we have such momentum in the payer community right now, welcoming of NBPAS among major payers, smaller payers, and major payers are aligning policies across their enterprise. So our hope is that this speed bump will be mostly gone in the near future. And I'll give you a little spoiler. We're hoping to have a really big announcement again in about 30 days. So some more good news coming on the payer side. So finally, to wrap up, who really makes these decisions, and how do you as a physician have the ability to impact change? Well, the first thing is that you came here tonight. You are educating yourself on the words and the standards and the accreditation. And that's the hardest part, to even kind of scratch the surface of this world to be impactful. So quick, final review. CMS has standards. Payers must follow them to be accredited. They're accredited by outsourced private accreditors with deeming status. Nearly all of them must get accredited and adhere to these standards. However, as we kind of discovered as we went through this, there is leeway in payer credentialing policies, and typically they come from the top down. So typically you have a chief medical officer. Typically it's in the C-suite or the sub-C-suite of medical leadership. But what I can say, and an important takeaway from anyone in the room tonight who is an NBPAS certified physician thinking about it, or if you work in a payer at a major insurance company and you'd like to make this change in your organization, we see every day how important and how strongly policies and organizations are positively influenced by the physicians who are employed or enrolled with those organizations. So I hope that this information is a little bit helpful and can take some of your conversations in your office, in your C-suite, in your hospital a little bit further. Excuse me one second. So finally, just want to talk about the value of NBPAS. So when you have those conversations, we think there's so much value. We're so proud to offer a different streamlined alternative for continuous learning. So we offer continuous learning that is rigorous, specialty specific, relevant to unique patient populations. On the workforce and physician shortage side, we're in an unprecedented time of physician loss, loss of access and loss of access to much needed care. It used to be a rural problem. It is no longer just a rural problem. So we know that a streamlined certification pathway reduces burdens on our physicians. It means more physicians stay in practice, improves a payer's network enrollment, and ultimately helps take care of the patients in their network. And something that I did not mention earlier, but to any payers in the audience tonight, it's a very big line item in many organizations' budgets to pay for primary source verification services, and we provide those at no cost. We believe as a nonprofit organization, our job is not to make as much money as we can, but to remove friction points in the healthcare system as much as we can. So as part of our mission, we provide those services to organizations at no cost. And finally, from the payer perspective, I think MOC requirements are very quickly becoming largely indefensible. There was a new study that came out they studied I think it was I can't remember the name of the journal. It's a radiology journal. But they found that the lifetime cost is $90 billion for maintenance of certification, and the evidence supporting the clinical benefits of that are still really not in existence. And so to require something that puts that level of burden, not just on our physicians, but on the larger healthcare system is really hard to defend. I think there's a good parallel with prior auth. I think it's hard to defend things and require things that aren't really improving patient care, and certainly things that are driving our physicians out of medicine. So we really do strive to support physicians, staying current with their care and knowledge, and of course, by extension, their patients. So that wraps up my deck. We'll have some time now for questions. Again, this is our first run at this. We have several more scheduled in the future, so we appreciate your feedback, questions to our info email box, info@nbpas.org. And please save the date if you found this informative and join us for session 2, which will cover state licensure, all issues related to state licensure and the interstate medical license compact. That'll be Tuesday, May 20th, again at 7 p.m. Eastern Time, and we can pause for questions. And I'm going to turn off my share.
We have lots of great questions. I think there's quite a few around some of the, continued issues that physicians are facing, getting credentialed at different hospitals that are requiring ABIM certification.
Okay.
What can they do to change that? How can they advocate?
Sure. That's a terrific question. So I think one of the biggest pushback points we've heard from hospital administrations has been just the fear of not getting reimbursed. And when I sit down with hospital leadership, what is stunningly consistent is that they have no issue with the National Board of Physicians and Surgeons. They understand it, they get it, they appreciate what we do. Their main concern is the bottom line. And so one of the reasons we focused so heavily and why we continue to focus so heavily on the payer market is because we need those payers to adopt and get on board, because then we talked about friction points. We remove that friction point and it makes it so much easier for a hospital to get on board. So I think that's number one. That's something we're doing to remove that pain point. Number two, I like to say that sometimes it takes 3 Congresses to pass a bill. And what I mean by that is that sometimes the first conversation, and I just want to sort of encourage and cheer you on, because sometimes the first conversation is just the door opener. And we do hear that physicians get no's. And then the second conversation we get, well, actually, we don't know anything about this. Why don't we have a presentation? And by the third conversation, we hear, this makes so much sense. Okay, we're in. Let's change our bylaws. So I think it can be a process. Every hospital is different. The culture of every medical executive committee is a little different. And so I think it just depends. We do have tremendous resources on our website. In fact, we have a letter that you can send to hospital leadership announcing some of the major changes on the payer side. And again, we're anticipating another really significant one in the near term. So you could certainly send us some messages and we're happy to help. And also, I would encourage you to go to our website, nbpas.org, look at the resource page. If you feel like it doesn't have exactly what you need, then please reach out.
And you covered quite a bit of that, some of these other questions about educating payers. And maybe we can share that we've been reaching out to major payers to educate them on the Elevance change, to encourage them to learn more about that and to adopt similar language. We have a couple questions.
And Katie, if I can just tack on to that, and the announcement we're anticipating in the near future came out of that effort. We spoke to a physician at a payer who is certified with the national board, and she's like, darn, why didn't I think of this? Great idea. So yeah, we're super excited. So we are actively working every day on this.
We had a quick question about ACGME, which I think is in later course. We'll be touching base on the ACGME.
Okay. Did you want me to
Words
touch
that
on
matter? Maybe just touch on some of the some of the topics that we will be covering, because I feel badly we're not answering all the questions because we're going to go into them in a later.
Sure. Yeah. So the ACGME, I'm just going to assume everyone is mostly familiar. They accredit all graduate medical education in the country, and they do have right now current. We talk about those words that matter. They added in current or active board certification through ABMS or AOA for most of their academic positions. So hopefully you understand now that that means they're asking for an MOC requirement. We have engaged with ACGME. We continue to be hopeful again for positive progress. You know, I think ultimately medicine should follow the evidence and the data, and the data is simply not there. We will have a whole other session on ACGME and our efforts. And I will say that we have some new academic hospitals and hospital systems that have come on board, and they've navigated the ACGME requirement just fine. They simply tier the credentialing requirements. So if you're at this point in time, if you hold an academic position, they still generally require you to participate in MOC or be grandfathered. But we're very optimistic. We think the winds are changing. So.
I think that I think I'm looking through. I apologize. This is new to me, so I'm trying to capture. I just want to share a note that makes several very nice responses about how they've worked with their CMO to change their bylaws. Several said that changing the bylaws are incredibly important. We don't we have on our website resources to how to approach and even provided wording for how to change the bylaws? Maybe we could talk about that a little bit.
Yeah, sure. So, so if you're going to engage your, engage your hospital to change your bylaws to be inclusive of NBPAS, so people can get overwhelmed with, gosh, it sounds so hard. It's really very straightforward. So, on our info page, our resources page, we have a document. It's actually sample bylaws. We didn't make them up. These are actual bylaws. In order for us to confirm a hospital and put it on our website, we always, verify the bylaws to ensure that they are what we think they are. And so we've taken sample languages. Every hospital does it a little differently. There's a lot of different roads to the same place, and so you can certainly take a look at that. We also have we call it our physician slide deck, and we'll probably update that shortly because we've had so many tremendous wins and gains in the last 6 months. But it's a ready to go plug and play slide deck you can share with your colleagues or your MEC to help get the conversation started. And we are always here. We are a very user-friendly, physician-friendly organization, and we're in frequent contact with our physicians, and we're always here to help. I'm very happy to hear from you.
I'm going to post in the question answer box the website. You can go to find the recording and find the slides will not be, we could provide the slides separately from the recording. I don't see a problem with that. So we'll put a link to that as well on the website where you found the recording, and we'll have the slides there to download. I'm answering a few questions, quick ones. How many docs are registered at National Board of Physician Surgeons? And we have a little over 15,000 registered certified physicians.
In all 50 states.
Yeah. And did we already say over 250 hospitals that we know of?
We don't. Do you want to touch on that a little bit? That's a great point.
I'll let you touch on that. Or do you want me to touch on that? You want to get some
I'm going to take a sip of water.
Well, we have, yes, we only, we want to make sure that we don't post a hospital on our website stating that they accept us without truly confirming that and verifying that. So we do make sure to do that before we post. And the only way we learn about an accepting hospital is if one of our diplomates or someone emails us. It's very hard to know that. And so I believe we have many more than 250 actively accepting hospitals nationwide. So if you are currently watching this and you're working at a hospital that is accepting the national board, please let us know, shoot us an email. We'll call and verify. You don't have to do anything. It'd be great to introduce us to the right person. It'll make things easier. But we would love to continue to add to our numbers and make sure that other physicians know where they can go and work with the National Board certification.
Mhm.
Uh,
Absolutely. And I think I said it earlier, but it's probably worth repeating that some of our, greatest momentum and biggest wins have really come from our certified physicians who are out there in the world advocating. And I think the example I'll give is, this is something new. Healthcare, and I'll talk about medicine in particular. It's inherently a conservative discipline, and change is hard. And accepting new things and new ways can sometimes be challenging organizationally, and just changing your way of thinking. And there's always kind of a chicken and egg. So, well, I'll certify with you once you're everywhere. But it's so critical to certify, because then your institution, maybe you're there top performing cardiologist. Maybe, you're the most respected leader in the hospital. And so it gives them a connection between what NBPS certification stands for, the rigor, to demonstrate your expertise. And it eliminates so much concern and questions. Really, it's leading by example. And so I can't stress enough, Elevance is one of them. That came internally from one of our physician leaders, and who really started that process. And so, we're so happy again that you all decided to join us tonight. We're thrilled. I hope we made it as interesting as we possibly could. I know that sometimes information leads to only to more questions, but please reach out. We're certainly happy to follow up. And some of those questions may be more complex as well. So if we can help tease some of that apart, we certainly will do our best.
And final note that we're going to be sending out an email to provide you some links to the resources that we mentioned tonight. You can reply directly back to that email, and that'll go to both Karen and myself, and we will answer any specific questions. There's quite a few that I don't want to dive into tonight. It's quite complicated, but we would love to continue to engage and share what we know about those topics and those questions. Really appreciate everyone joining tonight. We look forward to continuing the series. Love your feedback. And if there's anything more we can do to make these sessions more interesting or more engaging, let us know. And I think we'll end there.
Sounds good. Thank you, everyone.
Thank you, everybody.